and tell you about a tissue diagnostic test. How many of you have heard about the work we're doing or even participated in the work we're doing on biopsies for Parkinson's disease? So a few of them. Okay, can I have the next slide? Again, I love slides, so don't get too bogged down. Dr. Beach and I wrote a paper a few years ago looking at where the Lewy bodies were in the brains of people with Parkinson's. And you can see here there are different stages. I can't tell you when you're alive what stage you are. This is an autopsy staging. And in some cases, the Lewy bodies are only in the olfactory bulb. That would be somebody who had incidental Lewy body disease. They lose their sense of smell. They don't have Lewy bodies elsewhere, so they don't have signs of Parkinson's or dementia. We only see it in the olfactory bulb. Some people have it in the limbic system and in the brainstem. When you get it in the brainstem, that's when you start to see signs of Parkinson's. And then up in the full part of the brain called the cortex, that's when you start to see signs of dementia. But what we also did, the Fox Foundation, Michael J. Fox Foundation funded us to do whole body autopsies. So instead of just focusing on the brain, I told you about constipation, about sleep problems, lightheadedness on standing, smell problems. Lewy bodies are not necessarily only here in the brain. And what we and others have done is we've looked at other parts of the body. And guess what? There's this synuclein protein clumped up in the gland called the submandibular gland, which sits right under the jaw. We can find it in the heart, find it in the esophagus, the stomach, the colon. We find it in multiple different tissues. So Parkinson's disease is not a disease only of the brain. It's a disease of the entire body. Next slide. So we were interested, one of the biggest issues was you can't biopsy the brain to diagnose PD. I mean, you could, but it would lead to a lot of problems. So nobody does brain biopsies. Go back one slide. Dr. Beach has pushed me over and over and over again to biopsy the olfactory bulb. The olfactory bulb is easy to get to through the nose. There's a plate there where the olfactory bulb sits right over the plate. It's called the cribriform plate. Many neurosurgeons said, oh yeah, we'll biopsy that. You know, neurologists, we're not very invasive. Neurosurgeons, very invasive. So they said, yeah, we'll biopsy that. Now, number one, if you biopsy or take out the olfactory bulb, for sure you're going to lose your sense of smell, so that's a negative. And number two, when you break the plate, there's potential to have leakage of spinal fluid, which can lead to headaches, etc. So I have so far been successful in holding back olfactory bulb biopsies, but would tell you that would be a tremendously great place to biopsy because everybody with Parkinson's, by the time they have the motor symptoms, we're pretty convinced everybody has synuclein or Lewy bodies in the olfactory bulb. Next slide. But what we then did was we looked at all the different areas of the GI tract, and you can see the submandibular gland was affected in most patients, the colon and rectum a lot less in our hands, in our research. Next slide. So we decided we were going to do biopsies of the submandibular gland to try to diagnose Parkinson's disease. And these biopsies are fairly easy. They're not without risk, but they're fairly easy. And you can see that the submandibular gland sits right under the jaw. You actually can feel it in your cells. And you know, when you get swollen glands, a lot of times you can feel enlargement here. That's the submandibular gland. Next slide. So we did a few things. Number one, Dr. Beach looked at autopsy cases. And what he found was every one of them, 28 out of 28, when he took the whole gland and sliced it up and looked under the microscope, every one of them had synuclein staining in the submandibular gland. That was pretty important. The next thing he did was he took 19 of those cases, he stuck a needle into the gland, and then looked at the tissue in the needle. And what he found was that 17 of the 19 were positive for synuclein. What does that mean? That means, like with cancer cells, if you do a needle biopsy, you may miss the abnormal tissue, because all of them had it when you looked at the whole gland. So this right away meant that if we do biopsies in living individuals, we might not get 100% positive. Next slide.
The biopsies that you're doing, are you just doing needle biopsies?
Yes. So the biopsies we're doing, we are just doing needle biopsies. Again, the ear, nose, and throat docs could take out the whole gland, and there wouldn't be much problem for the individual patient if we took the gland out. But it's fairly big surgery. It's not simple, let's put it that way. I think it requires general anesthesia to do that as well, so we'd have to really have a good reason to do that. But the biopsy, as you can see here, what we did was we put numbing medicine in the skin, and then we put the needle in through the skin into the gland. The needle snaps and takes a piece of tissue. We do that anywhere from 3 to 5 times, and then send the tissue to Dr. Beach. So in the first study, what we did was we looked at 15 Parkinson's patients who had the disease for more than 5 years. So this was to prove the concept that in living people, we would be able to find the same thing as we found in the autopsies. The second, I'll show you the data in a second. The second study we did was in 25 patients who had Parkinson's for less than 5 years. That was really critical because I showed you how inaccurate my diagnosis was for people at Parkinson's for less than 5 years. So it would help to have a tissue biopsy. We also did 10 controls, and I would tell you that all the Parkinson's patients had an abnormal DAT scan. So they all had loss of dopamine in the brain. Next page. Next slide. So, study 1, study 2. In study number 1, what we found was that, first of all, let's see, I just was going to show you that average age was 69, average disease duration 12 years. Study 2, same age, short disease duration. Remember, the goal was less than 5 years. Next slide. And here's the positivity. So number 1 is when we do the biopsy, the ear, nose, and throat doctors, Dr. Lott and Dr. Hinney, they're sticking a needle blindly into under the jaw area. In some of the cases, didn't have enough gland. They had tissue, but not enough of the gland tissue. 3 of the 15 cases didn't have enough gland tissue. But of the 12 that did, 9 were positive. 75% positive rate of biopsy. Similar to the autopsy study that he did. Main side effects, swelling and bruising right under the jaw. 25 cases that we did with Parkinson's for less than 5 years, 6 didn't have enough tissue. But what you see here, which we were really, really, really pleased on, was 74% of them were positive. So in the early cases, same rate of being positive as in the advanced cases. What was a little bit interesting, actually unbelievably interesting, is that 2 of the 9 controls were positive. Now that either means A, they're going to get Parkinson's disease and I don't see it on exam, or B, in the process of doing the biopsy, something caused the tissue to look positive. And so this needs to be checked out further. Again, this is not without side effects. The majority of people had some swelling or some bruising. Some of the people had a sore throat. So this is not completely benign, but potentially the benefits outweigh the side effects. That's what the goal of the research is to figure out. Next slide. Everybody who does a study, especially one like this, it needs to be validated. And it needs to be validated not by the people who did the first study. So we were really pleased in December, I think actually it was probably in January, I spoke to this group. They're from Spain. And they've been very interested in the same topic. But they also are really interested in RBD, REM sleep behavior disorder. So what they did was they biopsied RBD cases, Parkinson's cases, and controls. Now, one thing they also did was they used an ultrasound to try to make sure that they got enough tissue. They were less accurate than we were, which really made me happy because I was really pushing the ENT docs, why aren't you using ultrasound? And they said it won't help, and sure enough, we had more tissue than they had. Number one, they confirmed in their 12 cases that had enough tissue, 8 of the 12 were positive. So that's the first and only study to validate what we have done. But also of great interest was that 8 of the 9 RBD cases were positive. That means the subjects did not have evidence of Parkinson's disease or dementia, they just had RBD. 8 of the 9 of them had a positive submandibular gland biopsy. So stay tuned. I always get asked, should I ask my doctor to have a biopsy? The answer is no. This is another research tool right now. This needs much more validation. It also doesn't change what I'm going to do for you as an individual patient. This is trying to identify people with PD. Next slide. So I think it's going to be tremendously useful as a diagnostic test. It's not always positive. Why? Maybe the needle misses the affected tissue. But I also showed you it's possible they're not positive because not everybody being biopsied actually has Parkinson's disease. Next slide.
Oh, I'm sorry.
Falling asleep on me. So, why is this valuable? Number one, accuracy of diagnosis. Number two, maybe we would use this to qualify people to be enrolled in a study. It's possible that you would say, hey, listen, I'm only going to enroll people who had a positive biopsy because we want to make sure that they actually have Parkinson's disease. Number three is there are a tremendous number of studies looking at genetics, looking at the epidemiology, so population-based study, looking at other markers for Parkinson's disease, but none of them, or many of them, are not validated by autopsy. If we now had a way to diagnose with tissue people with Parkinson's disease, the gold standard for those studies would be biopsy. Next slide. Other groups around the world are looking at other areas. They're looking at the colon. Our data, autopsy data, was not positive. We didn't think we should go to the colon. This group and a few others have gone to colon biopsies. Next study. Skin biopsies. There have been a number of studies looking at skin biopsies. Again, in our hands, looking at the skin was not positive. The main issue with skin right now is that it's a ratio, meaning how much synuclein there is compared to how many nerve cells there are. So there's potential that that could be problematic for a diagnostic test. But because of all of this controversy, so to speak, which area is the best place to biopsy? Next slide. Next slide. Michael J. Fox Foundation is funding a study. It's an intensive study. It's ongoing. And what we're doing is in the same people, same individual patient, we are biopsying the submandibular gland, the skin, and the colon. And we want to try to prove using the same doctors and the same labs which ones are positive, which has the most positivity, and which is the best site. I'll be honest with you, if it were me, I hope the skin works. Skin biopsies are much more benign than submandibular gland biopsies. So a lot of people think that I'm really biased toward the submandibular gland. Well, I'm biased because we've been doing it and it's been great. But from a patient perspective, I hope the skin comes back positive. It would be even better if blood or saliva or spinal tap would be positive. Right now, there's no test from any of those that's been accurate enough, so we're collecting all of that on these same individuals. All of this is a one-time test. It's funded by the Michael J. Fox Foundation. We are still enrolling subjects. So if you have any interest, and the two groups, we're enrolling 3 groups. So people who have Parkinson's and are very stable on their medicines and have had the disease for more than 2 years and are stable, we've actually filled the group. We're doing 20 people per group. But what we don't have enough of are people who are newly diagnosed, have never been treated, and have had the disease for less than 2 years. So if you know people with that, please let them know about this study. And we also are looking for people who have more advanced disease, meaning they have motor fluctuations and or dyskinesias, have the disease for more than 5 years. We still need people in that group. Last but not least, we need controls. So people who have no evidence of Parkinson's disease or dementia, we're looking for controls as well. I do have some papers. I think you're going to hand them out, or did you leave them somewhere? If anybody has interest in this study, Amy Duffy is my coordinator, so she would be the person to call. There is some reimbursement, not enough to make it worth your while, but enough to say thank you for doing it. We're not big on paying people to be part of research. I don't think that's a good thing, but we do know that this is a really intense study, so there is some reimbursement for that.
And Jamie has.
And Jamie back there has some of these handouts afterwards if you want to get them. So this is really critical. Next slide. This is one of my favorite bullet points. Because the Brain and Body Donation Program with Dr. Beach is probably the best top 5 in the world, what we're doing is really top 5 in the world. Why? Number 1, we're enrolling people and examining them every year. A lot of brain banks and body donation programs just look at the medical records. If we just look at the medical records, we miss a ton of information. Lots of internists, even neurologists, don't write down a lot of things. There are a lot of people with tremor that know, if you read through the chart, you never see tremor. Yet I examine them, I see tremor. That's number 1. Number 2, you have to live in Maricopa County because the speed of autopsy is critical to this program. There is a 24-hour-a-day, 7-day a week, 365-day a year autopsy team out at Sun Health. The average time, or the median time, from death to brain being removed is 3 hours. The fastest program in the world. Why is that important? Because after somebody passes away, chemicals change, receptors change, tissue changes. So the faster we can actually do the autopsy, the better. So I am a 100% believer because the program clinically is really good. The autopsy rate is really good, the speed is really good, and you must live in Maricopa County to be part of this. I'm a 100% believer that the cure for PD is going to come from the people who live in Maricopa County. There's almost no question in my mind. Why is that? Because this tissue then gets sent to scientists around the world. Scientists who need brain tissue or other organ tissue from people with Parkinson's disease apply for research grants, and they get tissue from us to do the studies. So, volunteers from Maricopa County, in my mind, are leading the way to find the answers. Places to get more information, foxtrialfinder.org, that's the Michael J. Fox Foundation's website. Our website is called brainandbodydonation.org. We call it Arizona Study of Aging and Neurodegenerative Disorders because when we used to give talks and called it the Brain and Body Donation Program, it sort of turns people off real quick. So actually, Dr. Sabah, we all tried to come up with some sort of great acronym, and we came up with AZ-SAN. So I like that better, but it really is a brain and body donation program. You can't be in this study unless you're willing to have an autopsy at the end of life. And last but not least about that part is it's the ultimate gift. It doesn't help you in any way, shape, or form. That being said, it helps Parkinson's patients in society coming down the road is everybody who was autopsied with PD. We now, of the 28 people who were autopsied and we learned about the submandibular gland, they're the reason why we may have a biopsy diagnosis for PD. So I think that's always important. Amy is my coordinator at the clinic. Kathy Jo Davis is the coordinator at Sun Health Research Institute. I forgot to bring the Sun Health flyers with me. It just dawned on me. So if you need that or want more information, it's really a good program, and we would greatly appreciate having you part of it. Next slide. A lot of work I talked about. It is a big group. There are been some people who have come and gone, but I would say that this is a Mayo Clinic, Arizona, and Banner Sun Health Research Institute collaborative project. Recently, Dr. Sabah and Dr. Schill moved to Barrow Neurologic Institute, and so they're still part of the program. They're intimately involved. So it's now 3 institutions who are really, really critically involved in this research. So I'm happy to take questions, and I didn't see really anybody fall asleep, so I'm really impressed with attention, so thanks.
Does the medical examiner's office work with you?
Good question.
If there's a death at home, are they going to say, no, the 3 hours isn't being...
So good question. Is the medical examiner's office going to work with us? I actually don't know the answer to that because it's never come up that I know of. Now, Dr. Beach and the autopsy team may be aware that if somebody dies of circumstances that one wouldn't have expected, that there may need to be something with the medical examiner's office. But in general, Parkinson's patients who die at home, it would not be a medical examiner's case. I can find that out. Actually, again, I've been doing this 20 years now. I never actually asked that question. I get asked a lot about other organ donation programs, and we can certainly work with other organ donation programs. That's not an issue. But it is, I would have to find out about medical examiner.
You haven't spoken about DBS, but I was curious what the what the qualifications for a candidate for that would be, and the disqualifiers.
To have DBS surgery?
Right.
So the question is, what are the qualifiers and disqualifiers for DBS surgery? That's a talk in and of itself. In a really, really short comment, I would say that somebody that has Parkinson's disease, who has responded well to medication, who has developed fluctuations and dyskinesias, so twisting and turning that can't be controlled with medications, who is not cognitively impaired, would potentially be a candidate for DBS surgery. But there's a lot that goes into a talk on DBS surgery. It would be hard to give you all the things, but they've got to have PD, they've got to respond to medication, they have to have side effects that can't be controlled with other medications, and they can't have dementia.
Would there be disqualifiers, such as age or?
So the question is, would there be disqualifiers? Depends on the site. Depends on where you would go to be evaluated. So some sites will have an age cutoff. Other sites will have different age cutoffs. Have to be able to go through surgery. Have to be able to have a stimulator placed in the chest. Have to be able to go through anesthesia for the stimulator in the chest. So again, a ton of different qualifiers and disqualifiers in terms of surgery. Other questions?
I had a question about all your studies that you have the length of diagnosis. So is that from when they come to you and they usually have the motors still?
So anything I said regarding duration of disease or length of diagnosis, normally it's a historic question. So when did the symptoms begin, as opposed to being an exam question? And then we use the exam issue of when was the disease diagnosed. So in this studies, the studies I've done, we'll have two parts. We'll have how long have they had symptoms, that's historic. When were they diagnosed? That would be based on a neurologist, especially a movement disorder doc, making the diagnosis. So I'll use both. Usually, we usually like to use symptom onset. Some patients don't come to diagnosis by a movement disorder doc for 3, 4, 5 years, and there may be questions, but if they tell me they've had a rest tremor for the last 3 years, date of onset to me would be 3 years ago.
Could you talk a little more about Lewy's bodies and dementia?
So the question is, can I talk more about Lewy body dementia, or I'll call it dementia with Lewy bodies? As a movement disorder doc, and there's a paper that the Movement Disorder Society recently published. I was one of the authors. We don't think there's a difference between dementia and Lewy bodies and Parkinson's disease. More of the cognitive docs, they think there is a distinction. And here's the distinction that we've all used for years. If somebody develops motor Parkinson's signs and does not develop dementia until at least 1 year after the motor Parkinson's, the diagnosis is Parkinson's disease plus or minus dementia. If the subject, the patient, develops dementia either before the Parkinson's motor signs or within 1 year of the Parkinson's motor signs, we call it dementia with Lewy bodies. So right now, the major segregating point is, when did dementia develop? Within a year of PD, dementia with Lewy bodies. After a year of PD, Parkinson's disease with dementia. One last point. Dr. Beach, when he does the autopsies of these cases, he cannot tell the difference between PD and dementia with Lewy bodies. He needs to come to the clinical chart to determine when did dementia begin, because the brains can look identical. There can be Lewy bodies in the cortex, in the limbic system, in the brainstem, whatever. The brains cannot tell us the difference. It's when did the doc say the person developed dementia, and when did the doc say the motor signs began.
Do some people never develop dementia, long-term?
Correct. So we have a bunch of data now on developing dementia and Parkinson's disease. Not everybody with Parkinson's disease develops dementia. So, each study is different. There are studies that say 30% of Parkinson's disease patients develop dementia, and there are other studies that say 70% develop dementia. And it all depends on how long you follow the patients, how old the patients are, etc. But the research is wide, and so not everybody with PD develops dementia. Everybody with dementia with Lewy bodies has to have dementia by definition. And in terms, again, of treatments are the same. So we don't really treat DLB any different than we treat PD or PD with dementia. Let me just go back here for